Welcome to weekly unit number 8. This is a unit about system transformation with a specific focus on consumers and the use of Prop 63 as an example. The objectives for this module include: we're going to introduce you to the Mental Health Services Act, which probably most of you are very familiar with, but we'll at least establish some general agreements around what the Mental Health Services Act is. And then what we're going to do is we're going to use the Act to model policy implementation. So we'll actually walk through some of the initial components that had to be implemented under the Mental Health Services Act and some of the methods that were used to implement the policy. And then finally, we'll talk a little bit about an introduction to change management, and so essentially introduce you to various methods that effectuate system transformation, although in this weekly unit we're just going to touch upon the basics and get into something more advanced in a future unit. So the Mental Health Services Act is a great example of current, far-reaching policy change in the industry in which we work, and it has probably been the single greatest opportunity that we have had in a significant period of time to really effectuate change in the public mental health system. And consumers and advocates for consumers were very, very involved with not only getting the act on the ballot and helping get it passed, but they greatly influenced how the act was implemented in the state of California. And specifically, we're going to look at, in this weekly unit, a process that was developed to gather input from consumers and clients and other stakeholders. And so stakeholders is defined as all the folks that should be a party to that decision-making process, and how they created guiding principles that were used for the initial implementation of the Mental Health Services Act. So the Mental Health Services Act, it was Proposition 63. So by the virtue of its title as a proposition, it was a voter initiative placed on the ballot based on the collection of signatures certified by the state, and then the authoring of a proposition or initiative that gets reviewed by the Attorney General and the Secretary of State, or excuse me, the State Secretary, and that ends up on the ballot. So earlier in the semester, when we were looking at the framework and we established a model based on system administration and then oversight and authority, and one of those boxes on the far right, you had federal, state, and local level, or Congress, California state legislature, or a state legislature, and then a local level like a board of supervisors. And there was yet another box under that, which was voters and consumers. And so the Mental Health Services Act is a form of voter-initiated legislation. So in other words, it's policy legislated directly through the ballot box. So as we know, the Act appeared as Proposition 63, and that was in November of 2004. And it was successful, and it passed, and it became effective the following January, which was less than 2 months after the voters had adopted the Act. And of course, the basics to that Act included the imposition of a 1% income tax on Californians with income greater than $1 million. And that tax revenue stream produces probably on average these days on an annual basis somewhere around 1.6 to 1.8 billion dollars. Although in the last few years it's gotten down as low as about $830 million because of the economy. Okay, so to get into a little bit more detail of the Mental Health Services Act, some of the basic differences between what the voters approved and what actually occurred in systems transformation. We want to establish an understanding of what was actually implemented in different pieces, not necessarily all by the voter. So Prop 63 itself created three components in the Mental Health Services Act. And of course, as most of you know, MHSA has several more components than what you see here on the screen. But the three created by the voter initiative included PE&I, or Prevention and Early Intervention, WET, or Workforce Education and Training, and Innovation. Now, the Act also created the Mental Health Services Oversight and Accountability Commission, which is technically a standalone governmental entity within the state of California that has the authority to provide direct input and help administer the Mental Health Services Act throughout the state of California. So the commission meets on a regular basis and tackles a number of issues. Initially, they were providing guidance relative to how to complete the various plans under the Mental Health Services Act in order to be able to implement each component. And today, they are the final repository for the local county plans, since in the future there won't be a Department of Mental Health. Current legislation has found that the OAC, or the Oversight and Accountability Commission, would be the final receiver of the county plan, although they would no longer have approval authority, which they originally had. They actually held a hearing and approved the various county plans to implement the different components under the Mental Health Services Act. And the original voter initiative also created what was known as the Mental Health Services Fund. And so the Mental Health Services Fund was essentially a fund established at the state level that allowed for a place for income tax deposits to go in order to be distributed throughout the state and to the counties and other entities involved with the implementation of the Mental Health Services Act. And so part of what happened with the Mental Health Services Fund is, because this is an income tax revenue stream, it generates revenue in the for the current year later, after the close of the fiscal year. And so there's always a lag time in the revenue received from the income tax and when it's actually received and then put into use for program and that type of thing. So the state had been adding cash to essentially float that fund until the tax revenue would come in. And so there was kind of a true-up process, a truing up, or a settlement or a reconciliation process between the cash that was going into the fund and balancing that with actual revenues received. But the Mental Health Services Act, for almost every year in which it existed, except for essentially one or two, always produced a greater amount of revenue than what the state had to pre-fund in the Mental Health Services Fund. Now, what's changed recently with the Mental Health Services Fund, because of the legislature passing various changes to the administrative rollout of the Mental Health Services Act, has led to a lot of changes, and again, mostly driven by the fact that the Department of Mental Health will be going away soon, leaving a void for an entity that was responsible for managing all of this bureaucratic process that was created around the implementation of the Mental Health Services Act. But anyway, the most recent change related to the fund is that it's now continuously appropriated, which means that truing up process no longer becomes necessary, so the state doesn't have to tie up its cash pre-funding the fund. And the receivers of the funding, primarily the county and other various organizations responsible for the implementation of the Mental Health Services Act, aren't receiving like quarterly payments. They're receiving each month what is actually distributed from tax revenue that is received. So that creates cycles because income tax revenue on its best can come in on a quarterly basis, but on also on a more often an annual basis. But what it does is it keeps money from accumulating at the state level. In other words, if it's distributed every 30 days rather than quarterly or being held by the state for some kind of statewide program. Part of the reasoning behind the continuous appropriation was in order to avoid having money accumulate in Sacramento that would become attractive to the state legislature, and then they would begin to eyeball it and think about taking it. In fact, just recently, in the month of March in 2011, the Republican caucus had proposed that all of the revenue from the Mental Health Services Act in the next fiscal year be diverted to the state of California to balance its budget. So because of this, large bureaucratic administrative function that was created around the implementation of the Mental Health Services Act, primarily by the Department of Mental Health, really believing that they had a need to do certain things in order to make sure the act was implemented appropriately. And remember, the act became effective less than 2 months after the voters adopted it. So there was a lot to do quickly. So not necessarily all the best processes were put in place initially. So, the voter initiative did not actually create all the components that exist within the act. So, the first one that was implemented was CSS, Community Services and Supports, and that was actually a function created through regulation from the Department of Mental Health and not actually part of the voter initiative itself, although the voter initiative, spoke to providing services in the community in such a way as to increase access and be more welcoming and more culturally competent. But the regulation promulgated by the Department of Mental Health actually created the Community Service and Supports component, which was the first to be implemented under the Mental Health Services Act. And then regulation also created the CFTN, or the Capital Facilities and Technology. It was just recognized by the Department of Mental Health in implementation of the Act that true systems transformation would also require changes to electronic record systems and case management systems to better be able to implement the Act, and the potential for changes in facilities because primarily of the integration of services, and also because of the expansion of services that occurred originally under the Mental Health Services Act. A lot of providers and county departments of mental health actually expanded or created new facilities to deliver these services, or at least procured additional or more facilities than they originally had before the Act existed. So what really sets the Mental Health Services Act apart from anything else that we have had to do in the public mental health system is that it transformed that system with some few key components, the primary one being this notion known as the community stakeholder process. That planning around the various components of the Mental Health Services Act actually required the involvement of the consumers and clients of the services being delivered, the recipients of of those services being delivered, as well as other parties that really need to be part of the decision-making process around planning for the implementation of the Mental Health Services Act. And so there were actually various activities that were required of the county. So, for example, a posting once a plan is done for a component, let's say the workforce and education training component. So the county writes a plan around that and says what they're going to do, and establishes a budget. And we'll look at one of those, by the way, in a few minutes. But when they're done with all of that, they have to actually post it and distribute it publicly and have a 30-day comment period, just like you would see with the passing of an ordinance or a law, or perhaps the approval of a project, like a building project, and the Planning Commission has to give approval. That's actually what you're seeing is an imposition onto the system, the direct input of those that are affected by that system. So this created a whole new approach to community planning, unlike anything that most mental health departments or organizations had been familiar with. And so that really required a transformative process. And while that was articulated pretty quickly in a short period of time, there are major components of that stakeholder process that have survived all of the changes to the Mental Health Services Act, including this latest one as the Department of Mental Health goes away and the authority of the Mental Health Services Act is vested primarily at the local level, which was actually the original intent of the Act. And in doing that, removes a whole level of bureaucratic oversight that was created by the Department of Mental Health. I had to in the early months of the implementation of the Mental Health Services Act, I was directly involved with some of the focus groups that were used to create the guiding principles. And I remember walking into the Mental Health Services Act section of the Department of Mental Health. It was actually a separate building, and the office space just dedicated to the implementation and oversight of the Act was, almost the size of a football field now. Establishing a specific image may result in slight exaggeration, but it was ultimately a very large space. And it filled up because I had to go down there several times over several years, and there were a lot of folks doing a lot of work there. And I forget what the actual ultimate staffing ratio was at its height at the Department of Mental Health, but it was somewhere around 350 to 400 people. Today there are 19. So that poses a major challenge because everything we've taught ourselves around the implementation and administration of a policy known as the Mental Health Services Act, that's all changing. And ultimately, don't get me wrong, I think it's primarily for the better because of this dissolving of a huge bureaucratic process that just added time, and while it certainly added guidance and accountability, it also caused a lot of additional work that was taking revenue away from the provision of services where it really needs to go. So some of those new challenges, for example, once a board of supervisors approved a component plan locally or an amendment to it or an update to it, it would go to the OAC for a public hearing and a decision there, and ultimately accepted by the Department of Mental Health. Well, all of that goes away. The approval process, the furthest extent of the approval process is the local county board of supervisors. There is no higher approval process now than that, although the plan gets submitted to the OAC, but the OAC no longer has any approval authority over the local plan. That is totally vested in the local. So that poses significant opportunity. It poses some challenges in that there will be less oversight than there was, so there may be an opportunity for things to quite not go the way that they would be expected to, which is, there's a concern mostly from statewide advocacy groups, not necessarily local advocacy groups, that counties really aren't good at implementing the Mental Health Services Act, and, that they would just, spend that money on propping up existing programs. And we'll get into that a little bit later. So the implementation of the Mental Health Services Act posed a significant challenge unto itself because it really involved a lot of planning and engagement. And so initially what happened were statewide consumer groups created white papers or position papers around what they thought would be important to take into consideration when implementing the Mental Health Services Act, primarily position papers directed at the State Department of Mental Health. And we're going to look at the summaries of 3 of those position papers, which you actually were assigned in your reading. And those include the position papers from the California Network of Mental Health Clients, the United Advocates for Children of California, and NAMI of California. So the California Network of Mental Health Clients, which is an organization managed and run by consumers, which currently mostly has regional chapters, and which is actually an organization that's been having a lot of administrative difficulty lately. They're kind of going through some leadership changes and that kind of thing. But anyway, the summary from their position paper includes that the folks at the network were really concerned that all the Mental Health Services Act was going to do was just lead to more of the same old, same old. In other words, MHSA would just, supplant some other revenue source, and services themselves would not really change. It's just local government would have a new way to pay for them, and less likely not pay more, necessarily just switch those revenues from one source to the other in order to protect the original revenue source that was being used. Which really, when you think about that, is mostly Medi-Cal anyway. And the state's already making reductions there right now as we speak. So the other thing that the network wanted to make sure was that the implementation of MHSA resulted in giving consumers a choice, being able to practice self-determination, and actually practice a wellness and recovery approach to their mental illness. And as mentioned earlier, the network was also really concerned about how well counties would be able to implement the act. They really wanted to see a statewide implementation and have one entity responsible for that instead of 58. And this is actually, my anecdotal observation is that this is pretty common for statewide advocacy groups, that they have a tendency to distrust the local level, and then the opposite actually occurs at the local level. They distrust the higher level. And when you engage the local representatives that may be in a chapter or a membership of one of these organizations like the network, they would basically say they don't see it the same way, that they're happy with their local process. It's kind of like, well, I heard about that county, and then it's like, well, what county are you talking about? Well, I'm not sure. I just heard there's this county. You could ask that in every county and be told, well, there's this county. But no one self-identifies with that. So anyway, the network recommends that programs implemented under MHSA be consumer-run, that there be consumer involvement in both the implementation and the operation and management of the Mental Health Services Act, that consumers become employees of the organizations that are transforming because of the revenue from MHSA, and that stigma and discrimination be addressed throughout all of the components of the Mental Health Services Act. So the next position paper is the United Advocates for Children in California. And the position with the United Advocates was really that they believed in children's systems of care. And what had happened in California right before the Prop 63, the voter initiative, was actually put on the ballot, the state had been defunding the state's CSUC's Children's System of Care. So there was actually state revenue in the early 2000s, late 1990s, that was provided to the local level to actually create children's systems of care. And then later, a lot of counties received federal grants to expand or create and or expand those children's systems of care. And then Medi-Cal ultimately sustained a lot of those implementations of children's systems of care. So the United Advocates for Children in California were really, pushing that this was the model to be used. And regardless of that all of the approaches to implementation of the Act include evidence-based and best practices. United Advocates is a family organization, so they wanted the implementation of the Act to be family-driven. They wanted to see family partnership programs like peer mentor or parent-partner type of programs. And again, another common theme, doing something about stigma and discrimination with the Mental Health Services Act as well. And then NAMI of California made several recommendations as well, and they, again, as a family organization, specifically advocated for involvement, also including families, and they were really looking at following the President's New Freedom Commission, which I now see is misspelled on the slide there, so I apologize for that, but it would take major effort at this point to correct that, so just pretend that that third M is a N. And so anyway, NAMI came up with the following recommendations: that programs implemented under the Act be consumer-centered, that consumers be empowered, and that cultural competence be woven and be an important thread to the implementation of the Act. And they wanted to make sure that the state was not only flexible but accountable, and trying to find that balance between being too rigid because of accountability, but then being able to have some flexibility in order to be truly innovative and really be transformative in the implementation of the Mental Health Services Act, and that implementation of programs be strength-based in their approach. So the Mental Health Services Act posed a unique challenge because it required program planning processes to be open, to be cognizant of the public and their input, to be responsive, and to be able to listen. And so the implementation of MHSA really required this very unique creation of a stakeholder process of bringing all of the parties relative to the decision-making process together to do the community-based planning around the implementation of the Act. And one of the ways that that was done in California was the creation of the vision statement and guiding principles document, which was part of your reading for this particular weekly unit. And that process was created and held immediately following the voter approval of Prop 63. So within about 4 weeks after the adoption of the Act, a process was already unfolding at the Department of Mental Health to begin to plan for the implementation. And so this vision statement and guiding principles document becomes an implementation guide for community services and supports, which is the very first component of the Mental Health Services Act to be implemented in the state of California. And the vision statement was actually just to guide the Department of Mental Health in implementation of community services and supports. So the stakeholder process produced a specific set of outcomes that the Department of Mental Health used in the implementation of the Act. And so there were specifically 5 guiding principles that were created by the document initially. And those included consumer and family involvement, program and services, age-specific community partnerships, and cultural competence. So specifically under consumer and family involvement, the document spoke specifically to including consumers and clients in the planning of the Mental Health Services Act, its implementation, specific policies that were developed around that, how services are delivered, and evaluating to make sure that the programs implemented under the Act were actually doing what the provider organization said they would do. And actually create opportunities for consumer-run services. So most counties, if not all, have some type of drop-in center or community-based center for folks, kind of like a low-level engagement into mental health services, which is MHSA allows that because you don't have to be worried about the Medi-Cal billing in order to pay for that kind of thing using the Act revenue instead. But most of those drop-in centers are managed and run by consumers. Another principle was, having individual plans that the consumer and their family are directly involved in. This ultimately emerged as RAP plans. So the principles specific to programs and services include providing services that are accessible at the local level to allow folks to be treated in their community. In other words, to be able to remain a member and living in their community, because typically prior to the Mental Health Services Act, for individuals who couldn't be treated excuse me, locally, they were hospitalized. And in most jurisdictions, hospitalization occurs outside the jurisdiction, which makes it more difficult for family members to be able to visit. So that was a specific guideline. Also looking at eliminating barriers that exist in existing programs and guidelines and getting rid of those. Creating some new population age centers for the delivery of services. I mean, typically there always had been children's and adults. I mean, that's a typical division of services. But then the guiding principles for the implementation of MHSA kind of bifurcates that child population to kind of say that you've got children and then you've got transition age youth, or those teenagers or young adults who are no longer children but not quite yet full adults. And then the other population that has been growing and specifically became a focus of the Mental Health Services Act is older adults. And finally, doing something around the provision of services that are actually dual diagnosis provided services, so co-occurring disorders. So mental health treatment and substance abuse treatment are coordinated, often provided together and through the same provider. So another thing that's specifically important to the implementation of the Act was this idea of no wrong door. And so there was a strong principle in programs and services related to being able to provide a screening and assessment at any point into the system where an individual enters the system. And other guiding principles included that services be age-specific, as we mentioned, the bifurcation of children, and then adding the older adults. But more importantly, being more holistic in the coordination of services. In other words, we're not just treating the illness, we're treating the whole person, which could include influencing their employability in order to assist them in achieving wellness and their journey on recovery, and making sure they have shelter in which to do that, and opportunities to advance by expanding their education. And also a guiding principle around community partnerships, specifically that there be more collaboration amongst community entities that all touch the same caseload, coordination between the schools and the courts and child welfare. And ultimately to look at having MHSA help with the integration of services that may have been traditionally or currently provided through separate programs, or like siloing of programs, that efforts be taken to integrate those services and create systems of service, which is very similar to the children's systems of care. And then lastly, a guideline around cultural competence, with a specific focus on making sure that underserved and unserved populations are provided a welcoming approach to engaging the system, and that the cultural incompetence of the system not become a barrier for those individuals to want to be able to access the system, and being able to provide assessments and the delivery of treatment and other services in a way that is meaningful and makes sense to the folks from a cultural perspective. So lastly, the document recommends that there be a focus on outcomes and accountability. In other words, there be results generated from the efforts undertaken in the implementation of the Act, and that it be held accountable. That what was set out to be achieved in a proposal and a plan was either achieved, or the program was modified, changed, or deleted and changed into something else. That we're actually taking a look at this. And now, this has really been pretty variable throughout the state. There really hasn't been any good example of data collection being done on a statewide basis, but lots of examples of it being done regionally and locally, and efforts undertaken to address what the data results are in order to improve those outcomes. So specifically a focus on evaluation, creating policy and procedure, and making sure there's adequate training around that. Just recognize that some things may be provided better on a statewide approach. So stigma and discrimination as a standalone program within the Mental Health Services Act, stigma and discrimination reduction as a standalone provision in the Mental Health Services Act is being delivered on a statewide basis, which makes sense because there's going to be a lot of media buys, for airtime and TV time, and a lot of social media work done around messaging to the general population about mental illness in order to make it, more acceptable, better recognized, and ultimately better understood in order to reduce stigma and discrimination. And then, being able to dashboard programs by making sure that they're achieving what they set out to achieve, that we're collecting adequate data in order to be able to determine that, and that we're providing that data for others. And so in other words, we have an obligation to review that data and to use it in order to improve our processes. But now we've got this additional level of something that was once always public, actually having the public involved with it, because consumers being actually involved with the same employee committees and groups that meet to review and discuss what they're seeing in the data, that consumers are actually directly involved with that. And then actually the mandate now too, that data be reported to the local governments, the local counties, mental health advisory board, or whatever it may be called, where you live. But that data actually has to be provided to that board or commission now, and then they are now required too, as well, to actually do something about that data, to take a look at it, and instead of just developing an annual report where over the years it was just kind of a reporting out of what did we accomplish in the last year, to saying here's what the data says, and so next year here's are the goals we want to achieve as a result of what we think this data says. And then go through that full circle again, evaluate a new set of data to see if that actually was doing what we thought it would do. So then there was also this document, Voices of Stakeholders, which was really meant to remind folks and to influence the process from a personal perspective, that going back to earlier in the semester, and how do you influence policy development, storytelling. And so here really the picture that's being painted is that we use storytelling as well for implementation, because we have to be able to look at the implementation of a specific policy through a number of lenses. And what better array of lenses to look through, but other than those that exist at the receiving level, the folks, the users of the services, the consumers, the folks that actually benefit from what's being delivered, and getting their perspective, and recognizing that, including that, as an essential fundamental element of the Mental Health Services Act, this entire transformation of a system involving consumers, and just a real huge paradigm shift. And so in order to get folks to be able to tell their story and to share their lived experience, that the process for the stakeholders had to be an open and inviting process. And that, that there had to be interaction, that it wasn't just something that was created for reporting out by a bunch of state bureaucrats and essentially having a stale conversation around whether something will or will not be, because it generally has already been decided on how it would be, and in many instances decided in such a way that it's not really conducive to what would work at the local level, but clearly was viewed only through the lens of what would work at the state level. So creating opportunities to actually interact so that there's some give and take and education on both sides of the particular issue. But more importantly, actively listening and getting away from just doing some kind of presentation. And then, being able to paint an image of what does the future look like. In other words, describe the change, and give people something to think about and to look towards. And because now you're articulating it in such a way that they can see it, it becomes more tangible to them and therefore ultimately more achievable. So being able to describe what that looks like as an approach to being able to transform the system. So the ultimate piece of the community planning process is what was the process that created the county plans for the implementation of each of the components under the Mental Health Services Act. And so we're going to switch screens here for a second. You don't have to do anything. I'm going to do the work this time. And we'll switch screens to actually look at a typical example, a nice brief example for as brief could be in this particular planning process, that's for sure. But to give you an example of what the various documents that had to be created under the county plans looked like. An MHSA WET component for the organization that I run, Glenn County. And so we're going to pop through this puppy. But here's a certification page, and it's just got myself and my deputy certifying that we followed a stakeholder process that was articulated by law. And in this particular component, we're describing that process in a narrative form, what it was that we actually did. So you can see here that we created a survey that we passed out not only within the organization but through various components and entities throughout the community. We held 2 specific focus groups that address the needs of particular populations. So we just described how we did all of that, that there were 49 surveys received, which is, my county's pretty small, so that's not great, but considering most of those surveys were completed on behalf of an organization rather than an individual, it wasn't actually that bad. So this is an update to an original WET plan, so it's a lot simpler document. We certified the period of public review and comment gathering, and then describe when we held the public hearing and specifically the input that we received from the public hearing and what our response to that public input is. That's specifically required by statute now. So in this process, out of everything that has changed in Sacramento, this process hasn't. So then we describe each of the various activities that we're going to do under this particular plan. So I think there were 3 of those here. No, actually 4. That's right, because of the internships. So we had basically funding a coordinating position. So this just is a bunch of fluff around why we actually need a position like that. And the Essential Learning Program. This was actually part of becoming a learning organization. We created an online web-based, as time allows for, type of training on demand. And the usage has been pretty tremendous. I think we've got a ways to go on being a little bit more coordinated in the delivery of that particular program, but it is going. A Consumer Pathways program, which is to essentially bridge the opportunity for consumer to become an employee of the organization and going through a training process to get there. And then funding internships for MS and BSW students, really actually MSWs, and really essentially paying for their fuel and that kind of thing. And here's the summary funding. It's actually no longer called the budget. See there we get the this update was back in 2009 and 10. We can see that we had to, in Section A, estimate what we were going to get, which in this particular case was $450,000. That we were going to need roughly $349,000 of that. And then that broke down into, so the coordinator, well, that was probably about a 0.2, probably a 0.25, maybe a 0.3 percent position, 25 to 30% percentage of a position that does other things, wears other hats. The implementation of the Essential Learning online learning collaborative was roughly $150,000. Funding the Consumer Pathways, $35,200, and then setting aside $72,000 for internships. So MHSA has been a great example of systems transformation. And we've been able to look at what started as a voter initiative and became adopted policy, legislated through the ballot box, and then planned for, and the various approaches taken for implementation. So it becomes a great example of policy analysis. And we've been able to get into depth as to how that planning process was, primarily because the Act dictated the involvement of populations that had not normally been accounted for in the creation of mental health services and programs. And, finding ways to enact change and using methods of change management. Now, this is probably what was most frustrating for me during the implementation of the Act, because there are lots of approaches and methods to change management. But when you are truly transforming a system, you need to be able to provide guidance and direction specifically around how to do the change management process. And if you provide that guidance universally, then the rate of success has the tendency to be more universal in results as well. And we really didn't get that in the Mental Health Services Act. Now, there may have been some specific training opportunities around change management and system transformation, but the guidelines and direction were really all about how to fill out the form in order to pull down the money, to make sure you're spending that money appropriately, and actually delivering a program at the local level. And it really became more about creating all of the hoops to jump through in order to get the money and make sure that the money is spent right, that it became a lot less about what actually needs to be done in addition to describing and implementing a program. When you truly are trying to change the service delivery system, it really requires a change management methodology, which was really missing in the implementation of the Mental Health Services Act, that there wasn't a greater level of focus and guidance provided for that on a statewide level. I think we would have had even more sweeping change and change that would be more longer, have a longer life and be more meaningful and effective. So what is change management, and what are some approaches to change management? So I just want to introduce you today to just the basic concept of what change management is. And there's two phases to it. And the first phase is the assessment phase, and there's only 4 steps. So the first step is to identify the existing business model. So in the assessment phase, the first thing we're going to do is describe our model. What is it? What is it that we do? What does that look like? How are we doing it? That kind of thing. And then the next step is to be able to describe what the change looks like. So in other words, what is it that you want to be? So perhaps you are implementing a case management system, and the existing business model happens to be all manual paper files. There's actually, let's just say, there's no automation at this point. And where we want to be is to have an automated system, an electronic health record, an electronic case management, that kind of thing. And so we really look at what is it that we want to be, describe that model, and then describe, having already described, the model of what it is that you're doing right now, so that you can do the third step in the final step in the assessment phase, which is saying, okay, what is the difference between the existing business model and the model of where I need to be? What are those differences? And once you identify those differences, then you're able to plan around those specific differences, because that is where the change will actually occur. And so the second phase of change management, with the final step, is the implementation phase, where you actually develop the change management plan around each of those differences that have been identified between the two models. And what is it that you're going to do to be able to move the existing model so that it reflects the model of what you want to be. And so that, in a nutshell, is a very basic description of what change management is. And so using the Mental Health Services Act as an example of policy implementation, we can see how transformative it was, and processes that were used that were new to the entities that were doing the planning, all these new levels of requirements, but implementing them in different ways, which is part of the flexibility. But in order for systems change to be lasting, that change needs to be managed both during the planning and the implementation phase, but more importantly, it has to be nurtured over time, constantly monitored and adjusted for as needed. And that requires skills in change management and using change management methods to keep the system either transformed or moving in a transformative state in order to be able to meet the needs of new populations and different times, and to remain a meaningful, valuable, thriving organization for the people that come to rely on it for very good reasons. So we're going to spend a little bit of time talking about that last piece relative to change management, because that's a lot of what is missing in public sector policy implementation, is the true methodology and efforts that need to be undertaken that lead to true systems transformation. So it's important that you just think about this basic model here, because that in unto itself is change management. And we'll get into a little bit more detail in future weekly units and when we meet face-to-face to talk a little bit more in depth about this, because this is really, truly a skill that is normally required of a management and specifically administrative executive level membership of the organization. And so if you want to be able to operate that at that level, you need to not only understand the basic model before you, but really have a greater appreciation for a lot more extensive education related to change management. But if not, if you don't want to aspire to that, that's fine as well. because this is something that's always occurring. And the better that you understand it, it results in less resistance to it and being fearful of it because it's less unknown. It becomes more familiar to you, but more importantly, so that you're actually able to influence that change management process itself, because what truly makes a change management effort successful is a two-way communication between the folks who are implementing the change and the folks who actually have to live with it. And without that communication occurring in a bidirectional way, change management efforts would fail. But that's enough for now on that, because this is a little bit more of a topic that I want to dive into a little deeper and give you some varied approaches that have been really successful in resulting in not just systems transformation, but true culture change. Because if you can change a culture to what it needs to be and then be able to maintain that, then you'll be able to perpetuate the transformation. So to summarize this weekly unit, we've used the Mental Health Services Act as an introduction and as a model to be used to show you how policy was implemented relative to the Mental Health Services Act. This is one potential example of how we do policy implementation. And then, this introduction to true systems transformation, in this particular case, in this weekly unit, really revolving around the creation of a stakeholder process that allowed for the opportunity for direct consumer involvement and input relative to the community planning process and decision-making efforts in the implementation of the Mental Health Services Act, and to show you that that was a method that was used for planning and system transformation, and then ending with a basic introduction to the activity of change management itself, because to truly cause true lasting systems transformation, we have to have a well-planned and executed and ongoing change management effort to be able to be successful and to sustain that. So that's it for weekly unit number 8.